Good evening. My name is Jennifer Carey, and I'm here this evening with Dr. Guy Carmelli. We're coming to you from UMass Medical School in Worcester, Massachusetts. Our talk today is EM without the ED, distance engagement for students in the COVID era. And so we have no disclosures. So just over a year ago, most of us were anxiously following social media. We were turning to the news, we were watching the pandemic unfold in front of our eyes. While initially some thought it might not hit us too hard here in the United States, the scope of the pandemic soon became a reality. Quickly, the governor of our state took action to impose shutdowns, and our medical school followed suit. Then we saw the cases start to rise and spread. Leading up to this, we wanted to keep our students safe. We started by taking them off of our EMS trucks. We pulled them from our community sites and relocated all of our EM students to our main campus so we could ensure that everyone was following our new protocols that we were implementing daily. We spent hours upon hours upon hours rearranging schedules over and over again. And then just like that, they shut us all down. All the medical school clinical rotations were ceased. And in the blink of the eye, mid-shift for some students, they were gone from the emergency department and then everywhere else in the hospital. So what would they do next? We had a large group of soon-to-be graduating MS4s, and we also had a group of rising MS4s, many of who were interested in emergency medicine. So with the graduating MS4 students, they actually ended up graduating medical school early, and then they went out and joined the workforce. Many of these newly graduated medical doctors, I should say, worked in our hospital's COVID units before they started their planned internships. Meanwhile, the rising MS4s were sitting around. Many were bored out of their minds because they couldn't go anywhere or do anything. We weren't technically in lockdown, but as close to it as you could come. Students wanted to do something, anything. I received inquiries asking if they could do shifts, telling me they would sign a waiver, anything just to let them into the ED to work. Next slide. You can see our objectives here. Today we'll be talking about how to find ways to get students involved outside of the traditional clinical rotations. We will talk about all the different roles that they can serve in, and we will discuss how to rapidly and effectively put together a novel curriculum utilizing available resources.
All right, so before we get into what we did for our medical students, I'm a little bit of a med ed geek, so I cannot give a lecture without discussing some education theory, right? Let's discuss a couple concepts to explain why it's important to continue to try to involve students actively in clinical experiences in order to allow them to progress as future clinicians. Don't worry, I'm not going to bore you too much. I just want to mention two concepts that you may have heard about. So the first is the theory of learning that is situated learning. Here, unlike behavioral and cognitive theories of learning, which can occur independently or in the classroom, situated learning has a sociocultural basis and occurs with active participation within society or a community. Situated learning holds that effective education requires learning that is embedded in authentic contexts of practice. It's not enough to just provide reading material or videos or podcasts on emergency medicine and expect the same results. A student must live within the environment of emergency medicine in order to be able to incorporate their values, ideas, and concepts. Now, this participation and learning cannot occur in a vacuum. We need a proper setting to do this. Just like the phrase, it takes a village to raise a child, so too does it take a community of practice to grow a new learner. Communities of practice are groups of people who share a concern or a passion for something they do and learn how to do it better together as they interact regularly. The student needs to be surrounded by other students, learners of different levels, educators, support staff, in order to create a safe space to learn and grow. Basically, you take the content of what you want the student to learn and you incorporate it into the living curriculum put forth within a dedicated community of practice in order to advance in an overall learning. Okay, so let's talk about what we were able to offer at UMass for our medical students in order to continue their education within a community of practice of other EM educators. Now, Dr. Carey will get into all the logistics and nitty gritty of how we are able to do this, but I'll just introduce briefly some of the activities we were able to offer our students during the pandemic. The first being our field hospital. So, the city of Worcester opened a temporary medical station at the DCU Center in downtown Worcester. This temporary field hospital was meant to relieve pressure for the state's health system by adding 250 beds, which were meant for lower acuity COVID patients. We were able to put together a rotation where medical students voluntarily did shifts at the field hospital, caring for these patients from several different, with working one-on-one with attendings from different specialties, including emergency medicine. Furthermore, putting together the field hospital and the field hospital disaster rotation was no easy task, and we were able to get some students involved in the actual planning aspect as well, furthering their education and involvement. Then UMass had the COVID-19 Educational Community Project, which was a community outreach program for our at-risk and homeless population within Worcester. Here you can see students such as Blake Foster, and they were able to swab homeless patients for COVID-19 and distribute educational materials and homemade masks to help them. Furthermore, medical students were also able to volunteer for the Stop the Spread campaign, working with some of our ED attendings to swab the community at various sites in the area. Students managed to swab up to 1,000 patients a day through this program in a time when getting tested was a challenge or nearly impossible for some individuals. Along with the clinical exposure, we needed to substitute the in-person curriculum for a virtual aspect. We were able to get a lot of faculty to volunteer to give virtual Zoom lectures. Furthermore, myself and some of my colleagues put together a completely asynchronous, foundational 4-week virtual curriculum called the Grounded in Emergency Medicine, in collaboration with Academic Life in Emergency Medicine, which you can actually go on their website right now and view the entire curriculum. The content was a mixture of blogs and podcasts and chapters and high yield virtual content, along with pre and post test knowledge checks. And you can actually get a completion certificate for finishing the rotation. Our simulation curriculum, like many other institutions, also had to make some changes. We were no longer able to bring all of our learners into our sim center, so we brought in a few students at a time, and then we set up a telesimulation experience so students could continue to participate remotely. There are so many ways to incorporate simulation outside of the sim center. You can set up low fidelity sims in and around the hospital or medical school, virtual sim rooms. There's different kind of virtual gamification and escape room or other kind of online learning platforms that could simulate sim. Now, while there was some restrictions with our formal emergency department in having medical students, UMass did set up a low acuity tent right outside the emergency department, which we were able to get some students involved in a clinical experience where they were able to see some of those low acuity COVID patients that just needed a swab or something minor. And then finally, for more clinical experience, we were able to offer some students the ability to get involved with telehealth. So after patients left the field hospital, they got telehealth follow-up visits, which the students were able to participate in. And then finally, as part of the overall UMass vaccine effort, our department and disaster division, which you can see in the top left, along with some medical students such as Kara Kennedy, helped with the mobile vaccine program titled MVP, targeting populations with difficult access to healthcare who may not have been easily able to get to one of our mass vaccination sites.
So how were we able to accomplish all these things that we did? We were able to align everything quickly and effectively. As ER doctors, we are doers. We like to get things done and we like to do things quickly. We also had a group of very self-motivated students who were very eager to work. In our dean's office, the deans were having a really hard time watching this pandemic unfold and seeing the medical students not taking part in any patient care efforts. They wanted their students to have an opportunity to be part of the team and to serve the medical community. So there were a lot of good reasons why clinical rotations were shut down. student safety. We wanted to reduce the number of reduce the number of people to essential workers only. We wanted to preserve our PPE, and the list goes on. So as Dr. Carmelli noted, we set up this field hospital backed by the governor of our state, but it was really spearheaded by our department's division of disaster medicine. So this is an opportunity where we were able to bring students back. And then through a series of emails, phone calls, and meetings, quickly we were able to do it in a matter of days. So how were we able to send students to a COVID field hospital, even though they were prohibited from working in the hospital clinical rotations? Well, there were three main things that were key to making this work. First, the students were offered the opportunity to do this completely voluntarily. There's also a shift here in how we view the students. So here at the field hospital, they're considered an essential part of the team. Whereas in the emergency department or other rotations throughout the hospital, they're often in the learner role and they're an extra person, not an essential team member. And then third, we had ample PPE as it was provided through the state for us. So we were excited to have more hands on deck to help with all our COVID efforts. Our medical school deans were thrilled to be able to offer different enriching opportunities to medical students, because worldwide pandemics don't just come around all that often. And it's really exciting and educational to be a part of a team fighting a pandemic from the front lines rather than sitting on the sidelines watching others do all the work. So through the efforts and the collaboration of our dean's office, our med ed division, and our disaster division in the emergency department, our motivated medical students, and of course the support of hospital CEO, we were able to accomplish all of this. It also helps that our CEO is an EM trained physician from our department, and he has been working and volunteering on the front lines of the pandemic throughout. So additionally, because we weren't running all of our regular undergraduate courses and activities, we were really able to focus all of our resources to create a valuable rotation for the students. And so in addition to the clinical and community service that they were doing, we built a very robust didactic curriculum. So we reached out to attending physicians who we knew had experience with either disaster medicine, global health, infectious disease, critical care. And we specifically tried to find people who had perhaps given a lecture on some of these topics before, so that they could just take that lecture and modify it rather than starting from scratch. We also identified some of the best webinars and evidence-based journal articles available at the time, and we distributed them to the students for self-directed learning. Additionally, all of our lectures, because they were on Zoom, they were recorded, and so students who were working clinically during a lecture would have access to all the lectures and discussions later on. We also really tried to empower the students and give them the opportunity to steer the ship, so to say. We had students who ran journal clubs, so they had to select the articles and present them. We asked them then to post some of the meaningful information that they learned on social media. We had students who were orienting other students, so new students coming into the field hospital, they would orient them on how to do the work. And we really gave them a lot of leeway as well to find and create their own projects. And so all of these endeavors and all these projects by the students were recognized by the medical school as clinical rotations, and they did receive academic credit for them. Next slide. Our biggest project was the field hospital. And in terms of how we accomplished this, so in the top picture, you can see two of our students. One is Grant Lewandowski. He graduated last spring, and then Blake Foster, who's going to be graduating this spring. So students like these two helped build the hospital from the ground up. And so this was an experience where they really had, it was really hands-on. They were setting up and they were running a field hospital. They also got to practice clinical medicine once patients arrived in a fairly limited resource environment. And they then were able to recognize patients who were too sick for that environment and required a higher level of care. So they worked on transferring those patients out to the main hospital. They also used best practice and evidence available at the time to treat these patients. And they really got to see how continued research guides best practices. And as this was occurring at a very accelerated speed throughout the first year of the pandemic. So while these students were setting up and working in the field hospital, they learned about other opportunities that were available that they could pursue. And a lot of these opportunities were run through leaders in our emergency department. And so students were able to get to know us in these other arenas. working with the team really enabled students to find things that they were interested in, whether it was administrative things, so developing protocols in the field hospital, or teaching and orienting other medical students, or doing scheduling for the other medical students. They also worked on developing a follow-up system for patients once they were discharged. And then other students were more interested in some other community-based activities. As Dr. Carmelli mentioned, we had students who were swabbing the homeless population and providing community outreach and education to them. We had volunteers in the testing tents, and those testing tents were really geared towards working in very underserved areas in the city. And then again, the vaccination team that has been very active recently, both in a mass vaccination site, but also going out into the community. So these students all showed commitment, they showed dedication and motivation. It was such a pleasure to work with all of them and really get to know them in different ways than we normally do in the ED environment. And so we just wanted to now give you a chance to, or give our students a chance to tell you all directly more about their experiences working clinically during COVID. Next slide.
This whole experience will never leave me. The sense of duty that I developed and felt, as cheesy as it sounds, reminded me that, yeah, I made the right decision by joining medicine. This was what I dreamed of when I first applied to medical school, the opportunity to take care of others when there's a tremendous time of need. And that was both in direct patient care, identifying patients who were decompensating, alerting the team, and being involved in proning them, increasing their oxygen requirements, reporting to residents, giving our own thoughts on what was going on, to coordinating how are we going to monitor these people? How are we going to give these remote monitoring devices? We were also involved in with the residents and working for a follow-up plan and logging the activity, which patients needed to be followed up remotely, which patients had already good follow-up. For all those reasons above, it was incredible. What made it life-changing was the fact that that was all done together, this kind of like healthcare team family, so that we could take care of patients who were at the time so completely lost. There was nothing about COVID that wasn't terrifying back in April, and still isn't now. But to be able to just sit there and say, though we may not know exactly what's going on, we'll be there for you and offer that reassurance. That's something that that I was proud to be able to say that I could work towards, that I could spend time with patients, giving them that understanding of having someone there for them. So this was the best experience that I've ever had, from coordination of planning to patient care to understanding what my role was and what I wanted to do with my life.
The next video is a student who was more involved in community outreach projects. She worked closely with our team and also one of our local primary care physician, who mainly sees patients from the underserved communities, including specifically homeless population and patients with substance abuse disorders. Next slide.
I was involved in setting up and operating the facilities that we ended up relying on to care for our COVID-19 patients who were experiencing homelessness. Did involve a fair amount of clinical work. We were doing regular vital signs assessment, medication reconciliation, medication administration, and managing transfers back to the hospital when patients began to decompensate and become far more acutely ill. There was also a decent amount of serving meals and de-escalating interpersonal conflicts and trying to sanitize everything. And it was an incredibly valuable experience, both from a public health perspective and thinking about how to best provide care and best protect these patients. But it was also a really important project to take care of the most vulnerable patients that we have in our population here at Worcester, and thinking about what elements of care needed to be provided and how to do that in a safe and accessible way. And that process, not just of providing the care, but of setting up the systems that could do it safely and equitably, was an extremely valuable experience to have as a student.
And lastly, one more summary video, another student just summarizing her overall experience.
I had the incredible opportunity of doing a rotation at the DCU Center during the height of the pandemic last spring. It was an incredible experience to be at a field hospital during such uncertain times and really seeing how much medicine relies on interprofessional collaboration and teamwork to try to figure out something that was so new and so scary. I also had the opportunity to volunteer at several COVID-19 testing sites throughout Worcester, which was a very amazing experience in terms of being able to connect with the community, address their concerns, and at least feeling in a small way that I was contributing to helping out my surrounding community.
So as we look around at all we've accomplished as emergency physicians over the past year, I would say it's nothing short of amazing. In the path we have taken, it's opened so many doors for our learners to be part of something bigger, something entirely new, fulfilling, and enriching, and really towards the growth of themselves as a physician. So when you look around, use innovative strategies to find opportunities. Ask yourself, where can you use helping hands? Where does the community or the hospital need more support? Empower your students to take the lead in some of these roles. These opportunities can really make an impact in the students' lives, their education, and the hospital and the community.
Great. Thank you guys for having us.